patients. It's such wonderful people doing interesting things. So enjoy your weekends.
Sure are. Can you guys hear me okay?
Perfect.
Slides look good?
Yes, perfect.
Yeah, great. So yeah, thank you to the Hub for the invitation. It's always nice to be in this community. You might be asking yourself, primary care and delirium prevention, do they go together? Question mark. And hopefully I'll make a compelling argument that indeed they do. I've already been introduced. This is me. I practice in my academic clinical settings, many different places. So I get to see the way delirium can be prevented and also play out day in and day out. Pretty much every day, it's part of the work that I do. And most importantly, I am the daughter of a dementia care partner, the granddaughter of somebody living with dementia, and my guess is that many other people in this community have a similar origin story. So hopefully what we'll do today is review the age-friendly health systems 5Ms framework. We'll talk about delirium risk from a primary care perspective. We'll use the framework to think about how we can prevent delirium in our own practices. I'm going to talk a little bit about the patient priorities care tool and then show some really exciting Providence Epic tools that have evolved and developed since the last time I gave this talk a couple of years ago. So I think we're all familiar with age-friendly health systems. They're sort of, the framework is really the 4Ms, which is what matters: medication, mentation, and mobility. Providence and others have added a 5th M. We have added malnutrition, but really the idea is that medical care for older adults is complex. It's getting more and more complex. And this framework was very evidence-based, as many of us also learned and relearned about at the Dementia Summit, and centered around what matters to the person and to their people. And so we'll be kind of investigating this through the lens of delirium prevention for the rest of the talk. I encourage you all to put questions or thoughts or comments in the chat, and we'll get to them afterwards. So why am I talking about age-friendly health systems in a dementia echo? Well, we know dementia care is really whole person care, and it's really centered around the dyad, often, not just the person living with dementia, but the person who is helping them with their journey, and really not just about their health diagnoses, but most importantly about what matters to them. And that if we incorporate the 5Ms to guide the care that we're delivering, we can be more consistent and comprehensive in our care, and we can encourage those around us to do the same. And the argument I'll make today is that assessing and acting on these 5Ms can play a key role in dementia and delirium prevention. And so why do we care? Well, turns out that almost half of people in the community living with dementia will visit an ER every year, and 30% will be hospitalized. Hospital care is costly, which is important, but it's also deadly and risky. And getting hospitalized if you are a person living with dementia increases risk of many things, but in particular, delirium. And I think this has been shown in many places, and we've all seen it ourselves. So let me tell you a little bit about Pat. She is an 80-year-old person. She had a stroke, and it was like a second stroke, and that was during a hospitalization. She came in with dementia. She has this history of urinary retention, and she had a 1-week hospitalization, after which she went home with home health. We offered her skilled nursing facility care just because it was complicated and she had a new Foley catheter, but she's like, nope, I'm going home. And so we sent her home with some home health OTPT, an indwelling Foley catheter, and a new medication for depression. She's very hearing impaired. She has a help of an unpaid caregiver who happened to be a nurse. So that was reassuring to us, but not a live-in caregiver. She hates the Foley catheter, really hates it. And it turns out that she is cared for by our fellows. And so she gets home visits, which is really lovely. But really, maybe the most important thing to know about Leah is that what matters to her is the cat. Sorry, her name is Pat. Leah is the cat, and what matters to Pat is her cat, and that's why she wanted to desperately go home after this hospitalization. So these are her medical conditions, and I guess in the chat, if you would just think about which of these conditions predispose her to delirium. Yeah, pretty much all of them. Yeah. Dementia being the major one. Hearing loss, really significant risk factor. Constipation, yep. So this is her medication list. You will note that she is not on a number of deliriogenic medications. Maybe that's because she has a really impressive geriatric medicine fellow caring for her. But take a look at her meds and realize that meds are one of the major delirium risk factors, and Trang can tell us a little more after the talk, but and specifically new additions. And so you heard that she was put on an SSRI. Does SSRI like lead to delirium always or often? Not necessarily, but it's a new psychoactive drug on top of her brain disease of dementia, and it certainly could be a delirium risk factor, but depression can be a delirium risk factor too, right? And so we're trying to treat that and always balancing these things. The rest of this list is probably no surprise to anybody on this call, but especially being in the hospital recently, we want to look at electrolyte disturbances and think about hydration. She has hypothyroidism. Have we checked her thyroid? Should we check her thyroid recently in the hospital? That's a big question mark, because that could lead us down the wrong track. We need to think about not just the drugs we're giving her, but maybe drugs that she may not be getting, including if she had any pain, lack of analgesia, thinking about infection, reduced sensory input, like such a huge one, vision and hearing, especially in the hospital and afterwards. Sometimes people lose their hearing aids and their glasses in the hospital, and then they go home without them, and that's too bad. Urinary retention, constipation, big ones that we need to really be thinking about ahead of time, right? We're talking about prevention, and then cardiovascular issues that can increase risk of delirium. And Pat had a lot of them. And why again are we thinking so much about delirium in somebody living with dementia? Well, a vulnerable brain and added stressors is just the perfect milieu. The literature suggests that delirium superposed on dementia is less likely to be recognized, more likely to persist, and associated with long-term outcomes than delirium in those who are not living with dementia. And a lot of it has to do with acceleration. And so it's not that, and so in somebody living with dementia who may be living well with dementia, after they get delirium, they may not be living well anymore with dementia. And sometimes it resolves and sometimes it does not. So what do we know about prevention of hospital delirium? Because I think there's been actually quite a lot of literature on prevention of hospital delirium. That has led to a number of impressive interventions that happen in hospitals, including this HELP program, which will come up a little later, but that's Sharon Inouye and her team have shown, but multiple multi-component programs have shown that the combination of very careful medication use, fluid management, early mobilization, avoiding sleep disturbances, attending to sensory issues, thinking about the environment, all of these things can prevent delirium and do prevent delirium in the hospital. Well, what about our ambulatory practice? How do we prevent delirium in the clinic, day in and day out? Well, we're going to use our age-friendly health systems framework to sort of take a journey and think about from each element in the age-friendly 5Ms framework, how we might be able to prevent delirium. And so first and foremost, a lot of this is trying to understand what matters. So, as an example, Pat this cat is really what drives her. And so what you need to understand in a lot of these situations is what is really driving, what really matters to the person who you're trying to create a care plan for and their care partners. It won't be surprising to you that Pat is not alone in wanting to go home and wanting to be home, right? But how we make that happen in a way that is sustainable is a much harder question. But understanding where people want to be and what's important to them is critical. And so I've just offered a few questions that you can ask your patients to try to assess what matters to them. And so what's important to you today, what brings you joy, what concerns you most when you think about the future. And this one is taken from the patient priorities care model, which we'll talk about a little later, which is what things about your healthcare do you find too bothersome or difficult? Because sometimes what matters to people is that we stop bugging them so much. What matters to people is we stop sending them for so many tests and so many consults. And that we really need to understand about people, because others, they really feel very comforted by all of that. We could spend a whole time, a whole session talking about advanced care planning, and we do often with a lot of Barack's guidance. But this whole concept that the paper is important is shifting to the communication is important, and how do we talk to people about how they want to live now and not necessarily when the bad thing happens. And then really supporting the care partner. Obviously in this group we talk about this a ton, but in this case I want us to think about how do we train our care partners to identify and act on delirium and try to address it when it's early on. So again, here we are thinking about serious illness communication and knowing that understanding what's important to people about the type of care they get is critical to, at times, preventing a hospitalization, right? And preventing the hospitalization that can lead to delirium. And so I think some of this comes up when we're communicating with folks about whether they get surgery. Some of this comes up when we're communicating about folks about whether they go to the ER when something is happening, when they're, adult family home wants to send them to the ER because they're worried about their fever. And you're thinking to yourself, if I send them to the ER, their chance of getting delirium goes up, right? Especially in our ERs these days. I don't know how many of you have spent time in the emergency room, but it is the biggest sort of delirium factory that exists for so many reasons. And then thinking, process and framework when we do have these conversations with people, like, what do you want? Do you want to go to the hospital? Understanding what matters to them, understanding who matters to them. And then in green here, I just want to say we should be unafraid. We should be very comfortable giving people recommendations, especially when we think a recommendation can lead to prevention of harm. And including when that means do not get the surgery that you have been planned to get, or do not go to the hospital when we can potentially care for you at home. So I think I want to really encourage us to think about making our recommendations with this in mind and to not be afraid to share that. So moving on to medications, we want to assess and act on medications that can cause delirium. And if we need a medication, we want to choose one that doesn't impact the other M's, including malnutrition here, but mobility, mentation, and what matters most. And so I think the other thing that we want to be really, really good at, I mean, this is maybe the most important thing about delirium prevention that we have control over in primary care is medications. We want to be looking every single time at the medication list and identifying the medications that have delirium risk, which are these medications in addition to others. And I have a new slide I added next, which I'll have you hold your breath for, but I want to be really clear. This doesn't mean that these meds are never on our patient's medication list, but every time they are, we need to think about the risk. We need to think about them, especially when there's more than one. We need to think about them when they're happening over time and there may not be an indication. And then we need to be getting our deprescribing pants on when appropriate and thinking about ways to safely and effectively deprescribe. A link to them at the bottom, the anticholinergic burden calculator. Can you give me a thumbs up if you know what it is? It's one of my favorite tools. And in fact, I'll tell you later, we've got a cool thing in our EMR, but the anticholinergic burden calculator helps remind you not just the burden of a single medication that your patient is on, but their total burden, their anticholinergic burden score. And to be a really good delirium preventionist in your clinic, you're going to try to get that score as low as you can. I added this, everyone's favorite gabapentin. I heard on a Jerry Powell podcast that there may be as many as 1 in 8 older adults on gabapentin now, or a gabapentinoid. Like, that's a lot of people. And I'm thinking about this week a little bit more intently because I have an 85-year-old that has like severe sciatica, probably herniated disc, and like we've got him on a whole bunch of things, including gabapentin. And so I'm not saying never prescribe gabapentinoids, but I wanted to share with you that there's some growing evidence of gabapentin initiation and delirium, essentially, neurocognitive changes in older adults. And this isn't even people living with dementia. This isn't people with normal cognition. And so I think we need to be thoughtful and remind ourselves that gabapentin is psychoactive and that we need to be careful when we add that to other psychoactive meds. And the Beers list reminds us of this as well. So like gabapentin and opioids, for example. And then my favorite thing is just reminding everyone about anticholinergic risk, because I don't, like, it's so like common to understand this from this community, but you go outside of this community and like in the hospital and our colleagues in primary care who may not be, aware of this data really that shows cumulative anticholinergic use leading to dementia, are using these drugs with thought that they are benign. And so I ask you humbly to continue educating those around you. Another way to act on deprescribing is this great website called deprescribing.org, which has a beautiful kind of flow charts for multiple different classes of medications and how to deprescribe them safely. I think it's really fantastically well done and also has some patient-facing information. So moving on to mentation, this is preaching to the choir, obviously, but I want to kind of make the argument that early detection of dementia is critical for understanding a person's baseline in the hospital and being able to understand what we're looking at is that delirium, is that dementia, comes up all the time. And understanding the baseline and having a really good early detection of cognitive impairment can help us immensely care for people who may then be more at risk of delirium in the hospital, but also understand what is going on. And this is really important. And I'll share with you, it's sort of this idea of handoffs and like better handoffs. And some of the new tools in our Epic really help us. So do the screening and do the testing for early detection of dementia, and then document that and have that be have that easily viewable by a team in the hospital that can really change the care of this population. No surprise that addressing social isolation and loneliness comes up here, and addressing the care partner's well-being. These are really critical. Know the baseline, like what is the baseline? And there are multiple tools, and I'm just sharing some of them, including Barack and Jackie and teams programming cognition and primary care, right? If we get better at this and we do this more regularly, we assess and we act, I think we can therefore address all the other M's, limiting folks' risk of delirium. Mobility, we are keeping people moving, and this is what's coming up from some of our hospital literature, but there's no like why wouldn't it also be true out of the hospital, that we know that keeping people active and mobile is really important. So a little bit about nutrition and hydration. So we, just kind of thinking about this in a physiologic way, dehydration can lead to decreased brain perfusion, right? So like literally, like dehydration is a risk of delirium itself. And then aging and dementia can decrease thirst response. And inattention, right? Not sitting and completing a full serving of fluids, swallowing difficulties, all of these things contribute to that. On top of, the thing that we see as dementia progresses, which is eating problems. All of these put somebody, like, tip their scale into delirium really significantly. So that's why, one of the reasons why a little infection or a small stroke can really have such an impact from a delirium perspective. So what do we do about it? I think we coach people and their care partners on how to prevent this. So keep water close, set hydration reminder. There's all kinds of like drinking aids, adapted drinking aids that can be helpful. You don't have to necessarily drink a lot to stay hydrated. You can also have soup. You can also have smoothies. And sometimes a person living with dementia actually needs to have their care partner drinking in front of them. And there's that mirroring that makes it easier for them to drink as well. Staying comfortable and cool and providing, what matters to them in terms of their nutrition and hydration to really be impactful. So we've talked on Echo before a number of times about the MIND diet. What we know is that nutritional deficiencies can put people at high risk for delirium. And that the MIND diet's been really extensively studied, and it really is like the Mediterranean diet and the DASH diet together. And that even though in not too long ago in the New England Journal, there was a trial of the MIND diet for prevention of cognitive decline in an older person, and it was sort of a negative trial, I think there's really good reason to be counseling people on eating well. And at the same time, I find myself like talking about the MIND diet and then talking about limiting red meat, all these other things that we really know help people from a brain health standpoint. But then we have to be really careful not to like limit what people are taking too much. And also, especially as people are aging, to allow them to eat what they like as well. And so, I just want to like throw it out there that we know a lot of these things, like Mediterranean diet is like so much good evidence from a heart, a brain, and therefore a dementia and delirium perspective. We want to be careful we're not limiting people too much. So, what does dementia look like, and how do we make sure that our care teams are appropriately letting us know? And these are like people in the adult family home. It's the spouse who's taking care of her loved one with dementia. It's, I'm really talking about outside of the hospital. And because I think people are surprised when they see it, and sometimes they don't see it at all. Hyperactive delirium is certainly hard to miss, right? You get a lot of screaming, pushing, shoving, throwing, pulling, and wandering and restlessness agitation. Usually we hear about this. And usually the way it comes is the phone call from the adult family home asking for the atypical antipsychotic. But also we want to hear about that early. We do. We always think the calls when they come in of hyperactive delirium, and we think about what they're due to, and we try to do an appropriate workup. We also need to be training our care teams to look for hypoactive delirium, which is way more common and can show up with decreased activity, decreased speed of speech, reduced awareness of surroundings, listlessness, withdrawal. Who thinks that in an adult family home, when the maybe kind of spicy and excited or normally chatty person is lying in their bed and being quiet, like, how long is it going to take for them to notice, right? They're busy. And so we need to let folks know that they should let us know if they see changes like this as well. These are some tools that we can use. Again, these are tools we use in the hospital, but they're not, it's totally reasonable to consider using them outside of the hospital as well. This is, by the way, this is my favorite, and actually has pretty good evidence, and I use it when I'm rounding in the hospital. The two item UB2, who's heard of it? So basically it's tell me the day of the week and tell me the months of the year backwards. And so for somebody living with dementia in like a middle stage or more, it may be impossible to do this, but some people can. And if you ask people day over after day in the hospital setting, it's a good way to kind of see how they're doing from a delirium perspective. But this can be used potentially in the clinic as well. But this, I think, is really cool. This is an adaptation of the CAM tool, which is, the confusion assessment method here. This is an adaptation for a family member. And so what it really does, like any good clinical tool, it really teaches us about how to coach somebody to look for something. And so this is, I'll let you guys read it yourselves, but kind of asking the person about their family members' thinking, concentration, and alertness. And so I think that it could be really interesting to routinely review this with family members on our visits, so they know what to look out for. I mentioned this in the beginning, perioperative considerations. We know that surgery and anesthesia are potent stimuli to the development of delirium, and surgery can trigger neuroinflammation. What do we want to do preoperatively? We want to make sure we understand what the baseline is. So it's very reasonable to do a cognitive evaluation before surgery. That is not coming up on the majority of preoperative templates, I promise you. We want to, maybe the most important thing we can do, identify and try to deprescribe high-risk meds, and then think about what the condition is, which they're considering surgery for, what the risks are specific to your patient, optimize those risks, and then understand the balance for them, maybe not for you, them, the risks and the benefits. I will say I had a 96-year-old just get her second knee replacement. She has some mild cognitive impairment. She did great. This is not about age. This is about other risks, and dementia being a big one. Just a comment on this, I think this program that you may end up hearing about in your circles called Patient Priorities Care, and really what it tries to do is get at what matters most, related in part to people's lives and livelihood and families, but in part to their health care, and understand what's helpful or burdensome to them, and help them understand the trade-offs and make decisions. And it takes time. And so that's why I think the limitation in primary care, but there are facilitators in certain settings that are working on these programs that allow us to think about potential interventions, think about the patient's priorities, and then make decisions as you go along, as opposed to the doctor just being like, this is what you're doing, this is what you're doing, this is what you're doing, which is not the way we want things to be. And this is like the like a example of the template, and I just highlighted the last part of the template, which is for you. And this I think you could start using tomorrow. When you're kind of working through your CHF and your diabetes and your dementia care, you also might want to say, okay, have them answer this question. What is your most important health goal? And what do you want to do? So in this case, they said, your most important health goal is being less tired, having less pain in my hands so that I can continue to watch my grandchildren and volunteer in the library, handling books more often and easily. So I think this is pretty cool. You may hear about it in a clinic or a system near you. It's not rocket science either. Like we should be asking about these things regardless of this new program. Okay, so I think I shared a early version of this a couple of years ago, but this is in our Providence Epic. And so Providence Swedish, but not necessarily UW, are going to have this view. And so you go to your top, and Emma and others in the Swedish Providence system. I encourage you to, and Janine, encourage you to try this out. So you go to your search bar up top and you do 5M, and then 5M summary comes up. So you have to be in an active chart, by the way. It can't be in a chart review. And it will bring up a 5M summary, which is pretty cool. It is, only as good as the information that's in there already, but it highlights documentation that's pulled from a number of different places, including inpatient stay, including, in this case, the steady fall risk questionnaire scores from the Medicare wellness visit. The documentation related to what matters is also from a I'm not exactly sure where that is from, interestingly. Mentation, if you look down there, you would get a MoCA score, not if it's in a text, right? But only if it is entered in the ambulatory summary, ambulatory screening section of the note. But this has her mini cog, because that was from Medicare wellness visit. And then the medication part is really pretty cool. So they are able to link basically the Beers list to a patient's medication record. And so this is what it looks like. And what it does too is it separates this into the sections from the Beers list. So risk of major bleeding, risk of C. diff, avoid use in heart failure, for delirium, dementia, avoid with falls and fractures, because we know there's so many sub lists in the Beers list. This isn't like the best example just because there aren't a ton, but it's pretty powerful, I think, if you especially if you're somebody that may not have as deep a knowledge of all of these medications. This is the other thing that's really cool. If you're in any note in a Providence Epic chart, a note, you do meds anticholinergic, and it immediately pulls up anticholinergic medications right into your note. And that gives you the kind of inspiration, especially if you put it in a template of yours, so it comes up every time, to consider and act on your deliriogenic medications. This is a shout out. We're now a year and a half into our Care for Me companion cart, which is delirium prevention at Swedish, where we have a whole bunch of interactive and comfort tools and games for people living with dementia to prevent delirium in the hospital. So that's been a fun project to work on. So I am wrapping up, and we got plenty of time for discussion. We've reviewed the Age-Friendly Health Systems 5Ms framework. we hopefully now understand better the delirium risk from the primary care perspective. We can use this framework to actually actively prevent delirium in people living with dementia. You now have heard of the patient priorities care tool, and I've showed you some Epic-based tools that Providence has to improve handoffs and age-friendly care delivery. Some references that you'll get sent out later. And that's it.
Outstanding. I was just thinking we aim to make these sessions clinically oriented, pragmatic, and tool kind of practice transformation focused, and you have beyond delivered here. So thank you so much. Yeah, plenty of time for questions, conversations. We'll open it up. You can unmute and go for it. You can raise your hand, whatever you'd like to do.
I just changed my audio. Can you guys speak?
Yep.
Okay,
Yep.
perfect. I'm good.
Julie.
Yes, this is one thing that I always wonder when it comes to taking in what matters to the patient. For your case example, for instance, when it's I guess what the question would be kind of, how do you find that middle ground between what you think they need and what's important to them? And is there any way to help guide a decision when you don't understand why something's important to them? For the case example, it being she wanted to get home to her cat, and already as a provider, I might be thinking, maybe she needs a different placement, maybe she needs, I don't know. It's just, it seems still very hard to know how to quantify the amount of importance that what's important to them could be. That makes sense.
Well, I will say this is the reason why AI will never take over medicine. Because like this isn't like a 1 + 1 = 2 type of discussion, and it never will be. And so it's hard, it's nuanced, and the more you can learn about the person that you're taking care of and their circumstances, the better you can be at addressing some of these things. Sometimes they're crises, and we deal with crises related to the what matters most to people. And at the same time, the relationship that you're building sometimes, especially if over time it becomes more and more not in their best interest to do the things that matter to them, they may have more trust in you with time to kind of see that and agree with that, and they may not. I see that Lucia is on the call, and she knows what I'm talking about when we say there are certain circumstances when what matters most to people, including staying at home, is not at all what we think is best for them and what is objectively best for them. And yet we have to continue to walk the journey, and continue to, what we didn't talk about today is capacity, right? Which is very complicated, but continue to think about what matters to people and how that's playing out in their decision making. Think about their capacity and their ability to make those decisions, and continue to walk the journey with them to work towards the best outcome for them.
I'm wondering if any. Oh, go ahead.
Clear as mud, right?
Yeah, all the good things are. I'm wondering, and maybe Reza, you're going to speak to this. I'm wondering if any of our other community members have strategies or tips or things that they found helpful in navigating that.
Thank you so much for the talk. It was great. One of the very common things for delirium is when the patient wants to travel. And, this is season of travel season. I have many questions from the family members that what should we do? I personally tell them, it's better not to travel. It's better to stay in the area or having just one-day trip maybe for patients with more than early stage dementia. For other patients, I tell them, okay, if you want to really go to a trip, make sure that you go to the same place that you went, for example, a couple of years ago, last year, 10 years ago, or take the picture that you have in your bedroom, in your home. If try to choose a room as much as close to your bedroom, for example, and reorient the patient that, hey, we are in a trip. So do you have any other strategies that can help the patients and me? Thank you.
Well, it's such a good question. I think that understanding how much the travel matters to them is number one. And if that is like the thing that is very important to them, then it's like, okay, how can we make it happen in the most comfortable way possible? And so I think you've highlighted a lot of the things that we would think about. Is there no risk to travel? There will always be risk to travel for any of us, right? But getting people to go somewhere where they really want to go, I think is high value. Making sure probably the most important thing would be coaching the care partner, the travel partner in this case, on tips and tricks, and then making sure they can try to keep a really steady schedule even while they're traveling. Maybe Barack has more to add.
Yeah, I was in a complicated conversation with a patient this last week about this, and I mean, it really turned out that it was the care partner who wanted to do the traveling, and you know, he was the partner of the person with, you know, between mild and moderate dementia, who really didn't care that much about traveling. And so it was definitely like a process of getting to the point of like realizing that it was more his preference to travel rather than hers, and, you know, thinking through ways to set up respite care for her so that he could travel without her was like the solution that came up.
Good. And Karen, I see you just put in the chat a resource around traveling with dementia. Do you want to talk about that for a second?
You know, I think it kind of summarizes for people some of the things that we already talked about, that kind of maintaining routines, you know, anticipating that you're going to need more downtiming, making sure that there is like a low stimulation space wherever you go, you know, identifying a place in the airport where it's a little bit less chaotic, the family, you know, family's house or something like that. Some tips on getting through TSA. It's all in that document that's available.
We've also had some folks who have had really positive experiences with the Hidden Disability Sunflower program. That's a really lovely one too for getting through the airport. You know, everybody in the family wears it. It's not just the person with the hidden disability. So lots of good stuff there. Kyle.
Sorry, I'll turn. Yeah, actually, that's what I was gonna say. The sunflower.
Oh, sorry. Yeah.
No, that's great. It's great. I mean, again, it's so like I think that's what's really joyful about like having these visits is just seeing how everyone is just so different, and kind of like, I don't know, you kind of you get a vibe like if you're in the meeting and like they're constantly like referring to their care partner, maybe they would be kind of more happy if, you know, seeing their care partner happy like brings them joy in a way. Like I don't know, does that track for people? Nods, yeses, no. So I'm just saying it's so individualized.
Absolutely. Try and go for it.
Yeah, a lot of patients that I see that they love going on cruises. I think cruises provide a lot of activities for seniors now. You know, they have they have you know, they have all the programs for seniors to go. They feel like they would go on a vacation on a cruise ship. And if they want to get off the ship, they can. So if they go on with a partner who has some kind of disability, either physical or they can't go, then the care partner can go down to the port and come back up. So I found that a lot of seniors really enjoy cruises, and I also, if they can go with somebody that they know, if the patient has somebody a familiar face to go with, I think it helps too. So it helps both the patient and also the care partner as well, to be together. And then one can stay on a ship and the other one can go off the ship for a few hours. And then after she comes back, and she can enjoy her husband with all other activities on board, including the casino on the cruise ship.
And Karen has populated the chat with the dementia-friendly cruise options. As always, a wealth of resources. Carol.
I just wanted to circle back to Julie's question, which I thought was really important too, around the how to balance when the patient says something that matters to them, and like, okay, but now how do I incorporate that into actual care planning? Because I see this a lot with trainees and other practitioners, like, people say, okay, yeah, my cat, and then you write it down in the record. But then, like, how do you make that square with, yeah, but you need skilled care, and how's that going to work? So I just, I think it's really hard, and I agree with Carrie, AI is not going to solve it. One of the things I just thought I would share that the way I like to think about it is to probe for the patient's level of understanding of how that thing that matters to them, sort of how that is going to play out. Like, can they understand the consequences of deciding to go home because their cat is there, even though they are assuming some risk by doing that? And just trying to sort of play out a little bit and get them to say and understand the what ifs, them or their decision maker or sort of whoever's in the conversation, and sort of it's going beyond the surface of like, I have a one-liner thing that matters to me, and deeper into the like, yeah, but what about this? What about that? So just sort of, and then sort of using my, like, if I'm really worried about the decisions that are being made, just to not be afraid to express my concern. Like, they get to decide, but I get to say I'm worried, and kind of just living in that balance. I did also have a question, Carrie, for you. Some of the CAM and the other Delirium screeners that you shared, which are great, how are those? Do those work in people with a pre-existing cognitive impairment? Just because when I look at all those questions on the FAM-CAM, like, those are uniformly positive in a patient with moderately severe dementia. So like, how's that all work?
Yeah. I honestly don't know what the data says. I do know that a tool that you're going to use is better than no tool to try to remember the key features, right? And the key here is understanding what the baseline is, right? Because especially if you're dealing with delirium, what may look like delirium, or what may show up positive on a tool, you need to know whether that's different from what their baseline is. So I think sometimes when we're thinking about using these tools, and most of the time it's in the hospital, we may not know what the baseline is. And so we use the tool, and then what you need to do is you need to back out and try to understand from a chart review and talking to the family what's the baseline. And then you can, like, this is not the scientific way to go about it, but it's the clinical way to go about it. And then you can kind of say, like, wow, they couldn't say, they couldn't answer this question that was on this tool. And the family member is like, no, they would have answered that. They would have been able to answer that 2 weeks ago. That's the utility of the tool, but that all takes so much time.
Thank you.
Were you guys impressed with the Providence Epic tools that I showed? Like, they're kind of cool, and, geriatricizing the medical record in a way that really hasn't had a lot of attention. And again, they need to be refined, but I would encourage you all to ask your health systems to, get a way to make summarized. I mean, this AI might help us with eventually, but like summarized data on people that if you are only going to look for 2 minutes, you know where to look.
That strikes me as a possible didactic, how to work with your IT team to optimize your EHR, any best practices to actually get stuff done in a large system. We've got, a few more minutes. Any other points of discussion, comments, clinical pearls? Trey.
Hi, Carrie. How did you work with the Epic team? Did you work with the Epic team directly?
I didn't, but it was I am on an age-friendly steering committee, along with Dr. Babineau, who's also on the line, for Providence Health System. So this is 50 hospitals, right? And this was one of the initiatives. And so I did sit with an analyst to say what things I thought were important, but it wasn't my personal advocacy. And I like it's so complicated to know how all those, lines of communication work. The dot phrase was a pet project of a pharmacist by the name of Sharon Lee. Do you know her? Oh, you should know her. She's
I'm
really
gonna reach
cool.
out to her. Yeah.
Yeah, so she's a Providence, Oregon PACE pharmacist, and she's a med stopper, med buster extraordinaire. And so she really wanted to get this anticholinergic piece out in front of clinicians. And so she worked for a long time to get the dot phrase. And so, yeah, and how to pull in the right medications. But she'd be a good person just to kind of like pick her brain about.
Yep, that would be great to get that on the to work with Epic, one of the yep. Okay. How long do you know how long it took?
You mean like
Dot.
the 5M or the dot phrase?
The dot phrase and the 5M.
I think she was working on it for like a few years because
Oh,
I kept asking her about it. Any update on this? Any update on this? And then lo and behold, it happened. I can send you her. I was trying to quickly search her. You can find her. Lee is her last name, Leigh. And she
okay.
might even be willing to come, Chris, and talk on this teaching
Yeah.
environment. She's a really dedicated teacher.
Well, we had a cancellation on April 11th. It's very short notice, but yeah, if any of our esteemed community members have a topic that you are passionate talking about, or have a kind of a clinically oriented talk ready to go, you're welcome to present on the 11th. We'll find something else otherwise, but I just thought about opening that up. It'd be great to have our community here has so much expertise and great kind of skill sets. So the door is open. Offer stands. Any other last minute? If not, I want to thank you again, Carrie, for such a wonderful talk and just being such a great part of this community over the years. Just all the great work you do with training, fellows, and just wonderful. We'll give you a minute or two back to complete our 1 minute post-session survey, and you'll still have 3 minutes left over because we're giving you 4 minutes back. So it's my quick math on a Friday afternoon. Otherwise, we will look forward to seeing you next time, April 11th, and topic TBD. Have a wonderful weekend and enjoy all those great activities that you described.
Thanks, everyone.